Here on Game Changers, we're all about helping you stay ahead of pharmacy practice. But why stop at listening? You can earn CE credit for this episode and hundreds more by visiting CEimpact.com and logging into your account or creating a new one. Get credit, get inspired, and make your learning count.
Hey, CEimpact subscribers. Welcome to the Game Changers Clinical Update Podcast. I'm your host, Rachel Maynard. Today, we've got a really unique topic for our conversation, and it's one where pharmacists can play a pivotal role. We're going to be looking at acute rescue medications that are critical in time-sensitive emergencies, so specifically naloxone, glucagon, and epinephrine. And this is a hot topic for a few reasons. For example, OTC naloxone nasal spray is getting a new carrying case with the intent of increasing uptake by making it compact and in an effort to reduce stigma with more discreet packaging. Only about 10% of the general population currently carry naloxone. Plus, we've had some new formulations of these rescue products join the pack in recent years. We now have an epinephrine nasal spray, as well as a few ready-to-use glucagon products that are easier to give. So today, we'll clear up some confusion about where these products may fit in and how we as pharmacists can ensure that patients and caregivers have access to these products and know how to use them correctly. And I'm so excited to welcome our expert guest for today's discussion, who has lots of practical experience in this area, Dr. Wendy Mobley-Bukstein. So welcome, Wendy.
Thank you so much, Rachel. It's great to be here.
We're so excited to have you, and thank you for taking time out of your busy schedule to meet with us. But for our listeners who may not be familiar with you, could you just share a little bit about your background, your current role, and why you're interested in this topic?
Sure. I'm a professor of pharmacy practice at Drake University. I'm also, I refer to myself as a diabetes specialist, but when it comes down to it, cardiometabolic care perhaps is probably better as to what I do, but ambulatory care pharmacy pharmacist, I practice at Primary Health Care at the East Side Clinic and also the West Side Clinic here in Des Moines, which is a federally qualified health center. And so most of my patients are underinsured, uninsured, refugees. So many are English as a second language or perhaps don't speak English at all. And so really just trying to help everyone access healthcare in an equitable way.
Excellent. Well, I think that will probably come back in this discussion because we do want to make sure that access and insurance and coverage is not a problem.
For sure.
But let's just start out with getting on the same page about, I alluded to some of these rescue therapies that we're going to be talking about. So glucagon, naloxone, and epinephrine. And these are, I think, really important for pharmacists to be aware of and thinking about proactively because these are tools that can be life-saving for people in an acute sort of emergency situation. And we can also play a really important role in ensuring that not only the patient, but any caregivers know how and when to give these products. So to just make sure we're on the same page, if we're looking at those three drugs, so glucagon, naloxone, and epinephrine, give us an overview of when these are used, why they're used, and how they work, if you don't mind.
So I'll start with glucagon. Again, I'm a diabetes specialist. So glucagon typically used in those situations where a person is either going low, they know that they're going low, they know that when they go low that they become unable to help themselves. And so I typically talk with patients, and we'll come back to this, I think, a little bit later in the podcast. But typically I tell people, if you're getting to the point where you know that you're going to get to a place where you cannot help yourself anymore, let's give the glucagon. It's also used as a rescue medication for someone who's already gone unconscious from having hypoglycemia. And so the way that it works is that it actually stimulates adenylate cyclase to produce an increased cyclic AMP. So cyclic AMP actually helps promote gluconeogenesis as well as glycogenolysis in the liver, so that it helps get more sugar. The liver is able to put that sugar out into the bloodstream and increase the blood glucose.
Okay, great.
Naloxone works a little differently. So what it does is it's used in opioid overdose. So for those individuals who are on opioid medications, we would want them to have some naloxone. Again, would be used if a caregiver, loved one, bystander comes upon someone,
Mm-hmm.
they're unable to wake them, that would be the time that we would want to use it. And this is a pure opioid antagonist that competes and displaces the opioid at the opioid receptor site. And so again, we'll come back to kind of what does that mean, because it definitely comes with different effects once you give the medication. And then epinephrine is used for those anaphylactic reactions. So when someone is super allergic to something, where it can cause their throat or windpipe to actually close up, and
Mm-hmm.
so it stimulates alpha, beta 1, and beta 2 adrenergic receptors, resulting in smooth muscle relaxation. So we're talking about the bronchioles. It stimulates the cardiac tissue a little bit. It can cause a little bit of vasodilation within those beta 2 receptors as well. So it's going to help rescue that person from having that respiratory collapse.
Mm-hmm. Well, thank you for that overview. And I think one of the potentially differentiators that I think of with these products is with, well, I'll get your clarification on it. So I'm thinking
Okay.
with glucagon and with naloxone,
Mhm.
those are administered when a patient is already unconscious, whereas epinephrine, a patient could be aware of the fact that they are having these anaphylactic symptoms. They might be having hives, trouble breathing,
Mhm.
wheezing, and recognize, and they can self-administer. Whereas naloxone and glucagon are more often given by a caregiver. Would you say that's an accurate assessment?
I would say pretty close. I think as far as glucagon is concerned, again, it gets into that situation of like if the person has had hypoglycemia before, they
Mm-hmm.
may
Mm-hmm.
understand how they respond, and they may know that as soon as my sugar gets below 50, I am going to be at a point where I can't help myself anymore. And if they
Mm-hmm.
know, so this is why I love continuous glucose monitors so much, is if they know that their
Right.
blood sugar is 54 and they have a downward trending arrow, meaning that their sugar is continuing to go down, I would tell them to administer it if they
Okay.
can't physically get some sort of carbohydrate into their system at that point.
Okay.
But to your point, if you're finding someone who is on insulin, who's been on a sulfonylurea or a glutamide of some kind, and they are unconscious, my first response
Mm-hmm.
to that would be don't even worry about checking their blood sugar, just give the
Yeah.
glucagon.
Well, and so that's a great segue into my next question, which is really, I think there's often, especially from caregivers who may not be used to administering medications
Mhm.
and bystanders too, like you say, there may be some hesitation or delay or concern about, well, if I give this, is there going to be some kind of bad reaction? And I think helping to clarify when these medications should be given is so important. So can you talk a little bit about that?
Yeah, so I think, it's perfectly fine for individuals to give these rescue medications, especially, I mean, you don't want to just be like, oh, they shouldn't be sleeping, you should give a good
Sure.
like
Yes.
a, a good sternal rub to make sure that you're not just
Hmm.
like having someone really heavy sleeping, right? Like you need to make sure that they
Hmm.
are they are in this kind of unconscious state, and then being able to give it. I mean, I think that that's the big part. You know, glucagon, for instance, used to be the only product that was available was called a hypo kit. And so this is where it was a powder vial. You had a syringe with a little bit of liquid diluent in it, and you had to mix it up. And that could take some time. Now we have these other products that are available, room stable injectable glucagon, nasal glucagon. And so now that caregiver has a lot of other opportunities to be able
Hmm.
to help that patient. And not only with the glucagon, but you now have nasal naloxone, we have nasal
Hmm.
epinephrine. So we have these opportunities for caregivers to be able to help someone who they can't get an answer from.
Yeah, and so you touched on a few different points there that I think are really important. So being aware that they as you said, doing a sternal rub, making sure they're not asleep versus
Yes.
unconscious. But
Yeah.
that's usually a pretty clear distinction. I think most people can tell, and it's also the fact that there are, as I alluded to in the intro, lots of different options available to make it easier for people
Mhm.
to administer, to increase that comfort level, to help people feel empowered to be able to administer these if they feel that a person is in need.
Yes.
And so I think that's great. And that we've seen those developments over the past few years with all three of
Mhm.
these products is just wonderful to be able to encourage people to give it when needed. Are there any risks or harms if a patient or a caregiver, I should say, gave one of these products and say the person they thought was having an opioid overdose, they were not, they gave naloxone. Is there any concern with that? And let's apply that to all three of those drugs.
Sure. So I'll answer naloxone first because that's the one
Sure.
you asked about.
Hmm.
The patient's probably not going to be very happy because they're going to feel pretty bad. Because
Sure.
again, that naloxone is going to displace that opioid, which was helping control pain in most cases, and so they're going to have some pain again when they wake up, and they're probably not going to be very happy about that. But again, it's better, I would just say in general, it's better to give that rescue medication than, you know,
Yeah.
perhaps not giving it. The
Hmm.
glucagon, the patient is going to probably end up vomiting.
Hmm.
Just the how all of the gluconeogenesis and the glycogenolysis happens. So making sure that the person is on their side when that glucagon is given, because as soon as it starts to work, which glucagon takes about 10 to 15 minutes, depending on the preparation that you give for
Okay.
it to start to work. And so but when they do start waking up, they're going to be nauseated, probably end up vomiting, and so having them turned up on their side. With the epinephrine, the same. It takes about 5 to 10 minutes, depending again on the preparation versus the sub-Q versus the nasal. But they're going to start to feel, um, you know, relief from
Hmm.
the
Hmm.
perhaps shortness of breath and or the closing up of the throat and those kinds of things, but they may have some of those cardiac side effects. So that
Hmm.
increased heart rate, maybe that nervous kind of jittery feeling
Hmm.
from having the epinephrine. But again, I don't think there's any reason for you not to give those rescue therapies.
Right. We're talking about potentially uh, life saving. We're
Yes.
potentially saving a life versus some of the potential side effects that you just described. So it's sort of that
Yeah.
balance of when in doubt, give, I think is the bottom
Yeah.
line. And
Yeah.
yeah,
I have written on my notes in big capital letters, don't wait until it's too late.
right. And that's such an important point because again, if a caregiver or even the patient is uncertain or in doubt, when in doubt, give. Right. Don't wait.
Yes. Yeah, until it's
Okay.
too late.
Okay.
Yeah.
Yeah. Don't wait until it's too late. I think that's a great take home message. And again, thinking about the different formulations and products that we now have and
Hmm.
making it easier for people to give. I think the other consideration is getting it into the hands of the patient or caregiver. And I know you have some personal experience with this in your practice and how
I
you've been
do.
ensuring that people have access and are aware of these medications, sort of taking a proactive approach. So, can you tell us a little bit about that?
Sure. So again, I work in a doctor's office, and so one of the things that we've done with our electronic health record is we're building order sets. So for individuals who are getting prescribed insulin or they're getting prescribed sulfonylurea, for example, glucagon comes up as another part of that order set, so that the patient is going to then get education in the office, either from the resident, the physician, myself, my pharmacy students, someone is going to give them some education about that. We also are building order sets with the opioids as well to make sure that naloxone is given. But I think when you talk about standard of care and where we're at with pharmacy, I think what's really important is if you are a community-based pharmacist and someone comes into your pharmacy with a prescription for insulin and you review their medication list and you don't see glucagon on there, there is no reason that you shouldn't prescribe glucagon. And you can do that with the standard of care regulation that we have. Do you need to inform the physician that you've done it? Yes, you do. And you also need to give the patient education and or caregivers education on how does this work. But I think it's the same. We've had the statewide protocol for naloxone for many years, and it's the same. If an opioid prescription comes in, you can put a prescription for naloxone right into the computer. And now with the standard of care regulation, you don't even need the statewide protocol for that.
And I think you're based in Iowa, and just to be crystal
Yes.
clear, this is in
Yes.
Iowa that you're speaking for,
I
but there
am.
are
Yes.
more states, as we've seen,
Hmm.
passing regulations allowing pharmacists to follow this sort of standard of care where they have prescribing authority to be able to initiate these therapies in certain circumstances like you just described.
Hmm.
For our listeners, just to be clear, you want to know what's applicable in your state, whether your state
Absolutely.
has standing orders around these things.
Hmm.
Some pharmacies may have collaborative practice agreements set up that allow them to initiate various therapies, or it's just something to check with your state and be aware. But I do
Yeah.
think we're seeing movement, as you said, Wendy, to more states allowing this, and so just expanding the ability of pharmacists to be able to initiate these therapies and prescribe them for patients who are in need. Do you want to say something more about
Yes.
that? Yeah.
Yeah, I would say, I do know, I have a little bit of knowledge about like surrounding states. So I would say statewide protocols are really important. Collaborative practice agreements, if your state allows those. If not, I know in Missouri they do CDTM, so they have these certificates of drug therapy management that they can have, and so you can apply for different ones. And so applying to be able to do rescue therapies would be a way to think about that. So I think, again, knowing what your state will allow and being able to do that, I think the bigger issue for us at this point is being able, as the pharmacist, as the prescriber, being reimbursed for that. And so that's one of
Mm-hmm.
the things that at least here in Iowa, that we're really working through right now. Not having federal provider status for
Mm-hmm.
Medicare. In our state, Medicaid actually recognizes providers, pharmacists as providers if you're registered with them. So you have to go through a credentialing process to be registered with Medicaid in the state of Iowa. But then, with your commercial insurances, it varies, from plan to plan as to
Mm-hmm.
whether or not the pharmacist can be a prescriber. And so really contacting those different, major players, perhaps in your state, to find out if you could become a credentialed provider in their system.
Mm-hmm. And to be clear, that's billing for the service that you're providing versus the prescription itself and the product, the drug. So you're talking about getting paid for the education that you're providing, the documentation, the
Mhm.
initiation, that side of it, which is really important. But also, I do think we want to think about the coverage for the drug too. And maybe you can speak a little bit about that too, considerations for the patient with the drug costs.
For sure. So I think that that's another area where pharmacists can play a big role, right? If I send a prescription to the pharmacy for glucagon, I feel like then it's the pharmacist that should be able to say, okay, what are you most comfortable with at your home, right? Are the caregivers okay with giving
Mhm.
an injection? If they're not, then let's go with the nasal, or perhaps your insurance formulary only covers the nasal. And so allowing the pharmacist to help kind of choose the product for the patient, based on a lot of different factors. And
Mhm.
I feel like that, with the implementation of some of the different things that have happened over many years, I feel like a lot of that autonomy that we may have had in the past has gone away because we're afraid that, oh, if we get
Yeah.
audited, perhaps we're not going
Yeah.
to, we're going to have money taken away because we didn't have that. So I think that those are some different things, but I do see that if that prescription comes in, and I'm going to say generically
Mhm.
as
Mhm.
glucagon or naloxone, and you do help with figuring out which product is best, then obviously communicating back to the primary care provider that this is the product that we chose for the patient, because then not only are you giving them the information that they need to have in their electronic health record, but then you're also getting a verbal okay for you to be able to fill that prescription, and you can write that right onto the prescription. So kind of, it- you know, it works a little bit differently, and yes, it's a little there's a stepwise process that you're going to have to go through. But until we have, the pharmacist seen as a prescriber that can bill for those services, then we're going to have to do some of those things.
Sure, sure. And I think it's we need to be thinking about, as you said, not only cost and what's going to be covered for the patient for a particular product, but also the dosage form and how comfortable they or their caregivers, family, friends is going to be using it. So all of those considerations need to come into play when
Mhm.
thinking about what makes the most sense for your patient. So I love the idea of having it being written generically so that when possible, the pharmacist who's working with the patient directly can decide that. And to go back to the discussion around how you've got EHR alerts set up for people on insulin, for example, who then you are prompted automatically to think about glucagon and then you can prescribe it. Even in those states where there's not a standard of care or there's not a standing order or a collaborative agreement, I think there's still so much room for pharmacists to be able to communicate with
Mhm.
the patient, inform them about this as something that you should be aware of and asking your provider about, or even proactively sending a request to the
Mhm.
prescriber and saying, hey, this patient's on insulin, I noticed they haven't gotten a glucagon in the past, what do you think about prescribing this? And even providing, templates for them to support that prescribing. Go ahead, I see you.
Yeah, no, absolutely. I'm a 100% in agreement with you. I think that,
Yeah.
it is our due diligence, to make sure that we're helping protect those individuals. And so if they're on medications where they could need to have a rescue therapy, then we should be, trying to provide that for the patient. So absolutely, I think that if
Yeah.
they're not getting a prescription or a prescription is not coming through from their provider's office, then we should be, at least offering to call the provider's office and ask if we could have a prescription for that.
Mm-hmm. Mm-hmm. I think it's a great intervention for us to be thinking about as we're
Mhm.
working with patients, as you say, on a case by case, prescription by prescription basis, but also when doing med reviews and this sort of thing, to just
Mhm.
be having that on our radar as again a life saving therapy that might come in need someday.
Yes.
So let's think about at the patient pharmacist interaction side of things and when a patient's actually getting one of these medications. And I know
Mhm.
we can't spend time talking about all the different counseling points for these different products and they're nuanced depending on the product that you're getting, but what are some of the general themes or main counseling points, if you only have a minute or two with a patient, that you'd really want to drive home?
So I think number one is having someone in the home and or support system that also knows how to do it. And so really talking with them about like, I need you to have someone in mind that you can call. So I'm
Mm-hmm.
thinking of someone who's going low, who knows that they're going to need to potentially use that glucagon, like they're texting their friend, they're texting their loved one, and or with opioid or epinephrine, like recognizing, or I'm sorry,
Mm-hmm.
naloxone or epinephrine, recognizing, how do I know if I need to use it? And so talking through that, I think for epinephrine, each person may present a little differently as to how their symptoms may start. And so, I'm pretty fair complected. I start to get hives and you can see them start to appear on my neck and on, you know, pretty quickly, to know that, okay, something is probably going to need to happen. And then the shortness of breath starts to happen. And then you can start to feel kind of the throat start closing up, type of thing. Versus like with the glucagon, you can obviously notice that, but the opioid is going to be a little bit harder. And so, talking with people about if you can't wake me up, you haven't seen me in a couple of hours, you can't wake me up, this is when we need to use the naloxone. And so I think that would be my first um my first counseling point, and if it's the only amount of time that I have is that, and then how do you administer it?
Mm-hmm. Mm-hmm.
And talking with them about administration.
Hmm. Yeah, I think those are critical points clearly that the patient needs to know about. And also, in terms of helping them educate others, what tips do you have around that? Because we want to be sure that not only the patient, but also anyone who might be a family member or a caregiver who might be nearby and need to give that, how do we help them educate others to feel confident administering these?
Yeah, I think it's super important that we're destigmatizing. Um, you know, yes, individuals have to take insulin. Yes, there are individuals who have to take opioids for pain control. Yes, there are people who perhaps need epinephrine for different types of allergies that they have to different things in the environment or food or whatever it happens to be. But we need to destigmatize it and have people know that these treatments are here. We need to use them. Here's when we need to use them. And, relying on your support system. There likely many people have a friend support system, their family, anything like that, that they could, talk with them about, like, here are some things that I may need. I can tell you from my own personal experience, I learned how to use glucagon when I was 15, with my best friend who had type 1 diabetes. And so it's a necessary type of thing, but as a
Mhm.
15-year-old with your friend lying on the ground unconscious, it's a lot. But it
Mhm.
was something that was necessary in order to make sure that I could save her life if I needed to.
Mhm. I think that's just such a great story to think about, driving home the importance of
Yeah, I mean, this is life-saving, right? Like we
right.
we
Hmm.
we want to make sure that we are, keeping our loved ones, alive, and that's what these therapies are for.
Right, right. Along those lines, what is the general rule around, say the medication is administered, and then in terms of emergency care, do we always call 911 after one of these products is administered?
Yes. We definitely want to call 911. We want to get them in, because again, the drugs themselves work relatively quickly, but they don't stay in the system very
Mhm.
long. And so depending on, with an opioid, maybe you have some sort of long-acting opioid on board where the naloxone is not going to be able to displace all of the opioid that's there for the amount of time that it works, right? Or the person has taken too much of their long-acting insulin. And so we've got the glucagon there and it's working, but what happens when, it's done what it's supposed to do, and now the sugar is going back down. And so making sure that they're getting that, just in general, getting a good follow-up, and going and being checked out.
Yeah, so it's not only about the acute situation, which, as you say, could last longer than the effects of the rescue medication. And so they may need additional
Mhm.
care in a hospital to be able to manage that, but also helping to prevent this in the future as well. And whether there needs to be an
Exactly.
adjustment in their regimen, or education needs to be given around what triggers to look for, that sort of thing, that additional care is also needed as part of that follow up.
Yes,
Okay. And
absolutely.
then in terms of other key counseling points, the things that come to my mind are expiration dates. And especially as we head into summer, being aware of how to store these products properly,
Mhm.
ensuring that patients are not keeping them in the, I mean, we need them to be on hand, right? So that's sometimes a
Yes.
challenge. Have you had any good advice around managing that with the heat and that sort of thing?
Yes. So typically, we're telling patients, please make sure that you're keeping these with you. Room temperature up to about 77 degrees is okay. Storing them in your car in the glove box, not really an
Hmm.
okay place for
Hmm.
it to be, because that obviously could get much hotter in the summer. And so making sure that we're talking with them about that. But most of these rescue therapies have about a 24 to 30-month dating. I would say the epinephrine perhaps has a little bit shorter dating. Sometimes it's about 12 to 15 months, but the others are a little bit longer. And so it is something that I would say, if you know that you've dispensed naloxone, or you've dispensed glucagon, you've dispensed epinephrine, being able to run a report, contact individuals and say, hey, I noticed that we filled this about a year ago for you. How's it going? Would you mind looking at the expiration date on that, just to make sure that we're not needing to replace it? So I often talk with patients about, you might receive a phone call from us, to look at those expiration dates again, and just make sure that you have product that's in date that's going to work if you need it.
That's a really practical point, an idea of reaching out based on a report of who's received these products within the past year or so, knowing that the expiration dates vary, but always a good reminder to refill before you need it and before the expiration date has passed, so that they're not than struggling. I will ask one question that commonly comes up is, what if it is expired and they don't have a in-date product? Should it be given?
Yes. Yes. I would say I would say one of my colleagues at Drake has done some studies on, is epinephrine still good after the expiration date?
Mm-hmm.
And what a lot of their findings were is, yes, even though the product says that the manufacturer's recommended expiration date is past, they still found that it was active enough that it would do something. Now, it may not have the full
Sure.
the full strength action that you would normally get, but I would still give it. Of course, calling 911 is really important
Of
as well. So
course. Yep.
activating EMS right away, but also still giving. There's no reason, and there's nothing that I can think of as far as like, is there some sort of like, prodrug or metabolite that might be there that would be of, egregious, and there's really nothing there that would happen. I mean, I think that the biggest problem would be is maybe it wouldn't work to its fullest potential.
Mm-hmm. Mm-hmm. And I think we've seen that when there were shortages of epinephrine in the past, where FDA came out with extended durations of expiration dates so that they could be administered beyond that labeled
Yes.
date. So I think that's a good point to clarify. And it goes back to what was the phrase you used before? Don't delay.
Don't wait. Yeah, don't wait till it's too late.
Don't wait till it's too late. Thank you. I think that's just the main take-home message here from our discussion, and also being sure that they're getting that EMS and follow-up care as well. But
Yes.
also, I just want to bring back the idea that pharmacists are in such a critical position to be proactively thinking about this and initiating these when appropriate and legal in your state, but really having that proactive role. But Wendy, we're about out of time, so I just want to wrap up. It's our Game Changers podcast, so we always wrap up with the game changer, and we talked about a lot of really great practical points, but what would you say is the game changer that you want our listeners to walk away with today?
I think pharmacists are first responders. It's our opportunity to provide these medications to patients. If they're in the hospital, they're in the clinic, or they're in your community-based pharmacy. If they're coming in, they're on insulin or secretagogues or opioids, we should be offering them these rescue therapies if they're not receiving a prescription from their provider for them.
Excellent. Well, thank you. I think it's all about access and getting these life-saving meds into the hands of patients for these time-critical situations. So thank you so much, Wendy, for your expertise. And I loved hearing your personal experience with this. It was really eye-opening and enlightening. Thank you.
Thank you. Thank you so much for having me on the podcast.
Excellent. All right. Well, listeners, be sure to claim your CE credit for this episode of Game Changers by logging in at CEimpact.com. And as always, have a great week and keep learning. I can't wait to dig into another game-changing topic with you all next week.